Okay, good afternoon everyone, and welcome to this webinar hosted by the MRC HTMR Trial Conduct Working Group. I'm Chris Rogers from the Clinical Trials and Evaluation Unit at the University of Bristol, and it's my pleasure to introduce Ashma Krishan, our speaker today. Before I hand over to Ashma, please could I ask that everybody who's on the call this afternoon turns off their video and also turns off their audio, because otherwise other people will see your video as we progress through the webinar. Okay, so I think we just have one person who signed in as guest 11 who still needs to turn their video off, please. So while that's happening, I'll just introduce Ashma. Ashma is a PhD student at the University of Liverpool, and she's funded by the MRC Hub to undertake a PhD, which is entitled The Analysis and Reporting of Time to Event Data in RCTs and their impact on evidence synthesis and cost effectiveness. And her presentation today is on a review that she's recently undertaken on reporting of time to event analyses and the proportional hazards assumption in meta-analysis. Okay, so the presentation, Ashma's presentation, is going to last around 20 minutes, and following that there'll be an opportunity for you to ask questions or make comments. And you can do that either via the chat box, and I'll read out the questions for Ashma, or at that stage you'll be able to unmute yourself and speak to Ashma directly. Okay, so without further ado, I'll stop now and I'll hand over to Ashma for her presentation. Thank you.
Thanks, Chris. So as Chris said, my presentation today is going to be on a review I did on systematic reviews, which were looking at the reporting of time to event analysis, and in particular looking at the assessment of the meta-analysis. So the Cox proportional hazards method is the most method assumes proportional hazards, so assuming that the hazards are proportional or constant over time, but the assumption is often overlooked. There are other methods available for dealing with non-proportional hazards, but these methods are often. It is currently unknown what impact non-proportional hazards can have on overall conclusions in clinical decisions, so more guidance is needed, in particular on how to assess the proportional hazard. So the objectives of this review were to review the reporting of time to event outcomes within reviews and assess the reporting of the pH assumption. In order to identify all systematic reviews, a systematic search of the following databases was carried out. So we looked at the Cochrane database of systematic reviews, the database of abstracts of reviews of effects, as well as Medline, Embase, and PubMed. Our inclusion criteria was including systematic reviews that included meta-analysis CTs in adults and children of all parallel designs, which were reported in a full-text journal article or the Cochrane database. We included phase 2 or 3 studies, and third point was really important. We were including RCTs that had been analysed using a method that assumed proportional hazards. And all systematic reviews were published between 2005 and 2015 in order to capture the most recent methods and also allow the review to be manageable. And the systematic reviews we included had included time to event outcomes, which were included as primary or secondary outcomes. So we identified just over 1,700 reviews. After removing duplicate records and conference abstracts, we ended up with 634, which we assessed for eligibility, and we ended up removing 511 for a series of different reasons. So being cohort observational studies, systematic reviews including a mix of RCTs and non-RCTs, or even the analyses not reporting hazard ratios. And in the end, we ended up including 123 reviews. So the overall survival was the most common outcome reported. The majority of the systematic reviews had included studies in the two major disease areas, oncology and cardiology. And of the 123 reviews included, which included 956 RCTs, 28% of the reviews included aggregate data, 66% included IPD, and 7 of the reviews included studies that had used both IPD and aggregate data. And although all of the included systematic reviews used methods that assumed proportional hazards, only 27% of systematic reviews examined whether this was a reasonable assumption to make. So for the aggregate data, 60% of the reviews which are based on aggregate data used a random effects method to pull the data for meta-analysis, and 37% of the systematic reviews used a fixed effects method. And the methods were unclear for one of the systematic reviews. For the reviews including IPD and aggregate data, 43% of the systematic reviews used a Cox proportional hazards model fitted to each trial separately for the IPD, and then they pulled the IPD and aggregate data together using a random effects approach. For 29% of systematic reviews, they used a one-stage Cox model, which is stratified by trial, and then again they pulled the IPD and aggregate data using a random effects approach. And for one of the systematic reviews, they used a Cox proportional hazards model fitted to each trial separately for the IPD study, and then they pulled the data together using a fixed effects approach. And again, the results were a bit unclear for one of the systematic. For the IPD studies, 80% of the systematic reviews based on IPD used a one-stage method, whilst 19% used a two-stage method. And the methods were unclear for one of the systematic reviews to understand whether a one-stage or a two-stage method was used. So for the one-stage methods, majority of the trials majority of the studies were either stratified by trial or stratified by a covariate, so either a trial characteristic or baseline characteristic. And for 4 of the reviews, it was unclear what they'd stratified by. For the two-stage method, 73% of the Cox models were fitted to each trial separately and the results were pulled using a fixed effects approach. And for 27% of the reviews, it was unclear whether they had pulled using a fixed effects or a random effects model. So for the assessment of the pH assumption, for the aggregate reviews, none of the systematic reviews assessed the pH assumption, which is not surprising. For the IPD and aggregate data reviews, the pH assumption was assessed in 3 out of the 7 systematic reviews. So for one of the reviews, they visually assessed the assumption using a log cumulative plot. For another review, they used a gamma frailty model to test departures from assumptions, formally testing the assumption. And for one of the reviews, they again visually assessed the assumption using a log cumulative hazard plot, followed by including time-varying covariates in the Cox model to formally test the assumption. The results from assessing the pH assumption were reported in 2 of the reviews, with both reporting that the assumption was valid. For the IPD reviews, the pH assumption was assessed 37%. So for these reviews, quite a lot of them used more than one method for assessing the assumption. So first of all, visually assessing the assumption using something like the log cumulative hazard plot or the Kaplan-Meier curve. followed by using something like time-varying covariates to formally assess the assumption. The results from assessing the assumption was reported in 16 out of the 30 reviews, so just over 50%. So in 13 of the reviews, the pH assumption was reported to be valid. For 2 of the reviews, they reported the assumption was invalid and then used alternative methods. And for 1 of the systematic reviews, the authors explained that the pH assumption was valid for a few of the included studies, but invalid for 1 of the RCTs, but then did not go on to assess if the pH assumption was valid overall or not. So to conclude for this review, so this review considered 123 systematic reviews with 956 RCTs included, which were published between 2005 and 2015 in a range of medical journals, database of systematic reviews. 73% of the systematic reviews failed to adequately describe methods and results of appropriate approaches for assessing the validity of the pH assumption. Findings in this review demonstrate the poor reporting of the pH assumption in spite of previous recommendations to increase the reporting of survival analyses in general public, as well as improving the reporting of the pH assumption. I feel that the reporting of survival analyses has improved over the years, but I think there's still so much more work to be done on looking at improving the reporting of the pH assumption. And the poor reporting confirms that further work is needed to, importantly, understand what impact the violation of the pH assumption can have on the statistical conclusions and clinical decisions in meta. So I've included some of the references, and the next few slides are just on other work that I'm doing as well at the moment. So at the moment we're conducting a CTU survey on the analysis of time to event data, and looking at the survey of current practice. The survey is being sent to all registered CTUs in the UK. So if you work at one of the CTUs and you're still to complete the survey, then I can't stress how important it is that you do, because the purpose of the survey is to understand what methods are being used for analysing time to event outcomes in RCTs, and in particular understanding how CTUs deal with the pH assumption, and the results from the survey are expected by the end of the month. We're also looking at an RCT review as well to understand how well RCTs assess the pH assumption and the methods used to assess pH. So for this review, we've used a sample of the systematic reviews where the assumption was assessed, a sample where the assumption wasn't assessed, to identify RCTs to include in the review. We've included a mix of systematic reviews, some including data, some including IPD, and some that have used a mix of both. And in total, we've included 30 reviews with just under 400 RCTs. The data extraction for this work is still ongoing, but we're hoping the results for this review will be available soon. And this will allow us to understand whether the issues of pH assessment are also present within RCTs, which will allow us to understand what further guidance is required. We're also doing some simulation work as well at the moment to understand what impact can the violation of the pH assumption have on clinical decisions and overall statistical conclusions, and does it have enough impact to alter overall conclusions? So if you knew that it could actually have enough impact, would you then go on to assessing the pH assumption, knowing that what you were doing could actually change the results? And also, how robust is the pH assumption when it looks at the pH assumption may or may not be plausible? And also understanding how do the results from the Cox model compare to other parametric models and models which don't assume pH? And what impact does censoring or varying hazards on the pH assumption? We're hoping that the simulation work and all the review work that we've done will all help us in developing some guidance which can be used by many of you here.
Okay, thank you, Ashma, for a really interesting presentation. Certainly a lot of food for thought, and we look forward to receiving the guidance in due course. So now we have an opportunity for anyone who's on the call to ask any questions that they would like to of Ashma. And as I said at the beginning, you can either do that by putting your questions into the chat box or by unmuting your microphone and speaking to us directly. Okay. So while we wait to see if there are any questions coming in, I wondered if I might be able to kick off and ask you, Ashma, from the work that you've done so far, have you any thoughts on why that you think that the reporting of the proportional hazards assumption is so poor?
I think there's quite a few reasons for it, but a few of them are, I think many people probably just think if the curves cross, and if the curves cross in the Kaplan-Meier curve, they think that means that the assumption is not valid. But if they don't, then it's probably okay. But we have actually seen many cases where the curves don't necessarily cross, but the assumption may still not be valid. So I think it's always worth doing some sort of formal testing as well. And also I think a lot of the time people may not be testing it, because if it does come out that it's not valid, then what else are they going to do? I think especially with people trying to compare hazard ratios maybe across other studies and things, then people might be a bit wary about using other methods, maybe something like accelerated failure time model, which reports something like time ratios, or even using something like restricted mean survival time. And even though these methods, they're actually easier to interpret than hazard ratios, I think because it's just not really used commonly, I think people just won't really use those methods much. And I think also obviously people thinking that the Cox model is reasonably robust, so it's probably okay. So I think there's quite a few reasons why people might not actually be checking the assumption, or at least reporting it.
Okay, so would you actually advocate that people do formal comparisons or formal testing of proportional hazards and not just look at the data graphically?
Yeah, definitely. And I think there's quite a lot of examples from papers I've looked at as well, where just by visually assessing, they've gone on to fit the models. But I think when other people have rechecked it and used that data to assess what should actually be done, the results have changed slightly. So I think it's definitely worth doing both.
Okay. Does anybody else have any questions for Ashma?
Yes, please. This is Adam Streeter down in Plymouth Peninsula CTU. Can you hear me?
Yes.
Yeah. It's very interesting talk. Thank you. I may have missed it because I couldn't quite. The sound quality over the phone's not great at places. So give me if you did explain it. But on the previous slide, you picked out maybe one or two publications that didn't explain the Kaplan-Meier. So I just wanted to understand what you meant by explain Kaplan-Meier, explain KM. So I kind of missed that bit. Would you be able to expand upon that by that particular point on the slide?
Was it these references you were talking about?
No, it's in your results from your review. You had that's it. So explaining, examining KM curves. So okay, so I can see it because I mean, in terms of examining KM curves, do you mean just presenting them, or actually talking about the KM curves? Is that what you meant by that?
Yeah, so I think most of the time it was just one line saying that we looked at the Kaplan-Meier curves and they seemed okay, so we went on to just use the Cox model. I think that's what I meant by that.
Okay, so they didn't cross effectively, but no further interpretation of them then?
No, just looking at the curves and just visually assessing.
Yeah, okay. That's good, thank you.
Okay. Well, we have one question that's come in on the chat from Helen Thomas. And Helen is asking, do you think space limitations in journals limit the reporting of this checking rather than the checking not being done?
I think sometimes just putting in a line to say that we checked and we use this method, I don't think that would probably take up that much space. Yeah, I don't really think we're always looking for people to write up a paragraph on exactly what they did, but I think sometimes just to say that they did assess it and this is a method they used and it was valid or not, just 1 or 2 lines, I don't think that would probably take up that much space, and I think that's probably what we are encouraging.
Yeah, okay. There's always web appendices where you can put that additional information as well.
Yeah, definitely.
Increasingly these days.
Yeah.
Okay, does anyone else have any further questions? I can't see any coming in, so if I may, I'll ask my second question if I can. And I would like to ask you, Ashma, if someone's conducting a meta-analysis with time to event data, but only the studies that have reported aggregate data are available, so you've only got aggregate information, how do we go about checking that proportional hazards assumption in that scenario?
So you could digitize Kaplan-Meier curves if they were available, and for more and more reviews, or more and more RCTs and publications, they will make the Kaplan-Meier curves available. And then, so you can like obtain pseudo IPD, and then you can use the algorithm that's been suggested by Patricia Goye et al., where you can then basically get reconstructed IPD data, and then you can basically check the proportional hazard assumption that way. So that's again something that we are doing in our review, but I didn't have the results for all of them today, which is why I didn't include it in the webinar. And we are hoping by doing that, actually showing how easy it is to do something like this, and ways in which how to do it as well. So there are quite a lot of digitizing tools available online which are free to do. So yeah, so it's something that's really easy to do, and we do hope that people will actually use these tools more and more.
Okay, thank you. That's really interesting. So something I wasn't so aware of. Are there any other questions from anybody else? Okay, well, there don't seem to be any further questions coming in. So I think we'll probably... Oh, no, there is one, last minute one, when I thought we were going to wrap up. So that's just Rion for reminding me to remind everybody that when we finish the webinar today, there will be a link to a survey so that you can provide some feedback for us on this webinar and the webinar series that we're running through the trial working group. So please, we would very much encourage you to fill in that survey. And also, we're also very keen to have further speakers for our webinar series. We have a webinar lined up for March. We're going to have Claire Clement talking to us on the 14th of March at midday, but we are currently looking for a speaker in April. So anybody who would like to present something, either as a practice for a conference or presenting something that maybe you've already shown at a conference, you would be very welcome to do that. And please just drop us a line and we'll be in touch. And so finally, as we wrap up, I'd like to thank everyone for joining us today. This webinar has been recorded, including the Q&A session, and we will provide you with a link to that so that it's available to others and your colleagues who weren't able to join us this afternoon. So I think that's just about it. So I will stop there and say goodbye and wish everybody a good afternoon.